larger.
Are there any points that anybody want to bring up?
That was quite interesting. I mean, it is as actually Megan May, who was a former colleague of mine, when I heard about this first from her, it's been fascinating since then. And I mean, I guess a few questions or reactions, Danny, to your presentations. I mean, I suppose you mentioned sort of distinction between type 1 and 2 and how it affects. I mean, so we find that in this survey it's actually very hard to distinguish adults which one they have had. But I wonder if the 1947 paper was actually largely type 1 diabetes. I mean, there wasn't a lot, and if you say that they were there in the century before it, in the type 2 diabetes, and especially in sort of Middle Ages, is a much more recent thing to have had. And so I suspect that the farther back in time we go in these studies, we are probably dealing a lot more with type 1. So that's sort of one comment. I guess the other one, in terms of where the research might be going, is that I wonder if actually studying this in children and adolescents in relation to other infections, so not TB, might be an interesting thing to do. So if it actually does something to mechanisms of being more susceptible to being infected and or becoming a better environment for bacteria to grow, children who have type 1 diabetes, and actually increasingly type 2 diabetes is showing up, early onset one, whether they may not be actually a sort of good to see simpler infections, so not TB, upper respiratory infections or lower respiratory infections where they show up. That's sort of questions of where one may want to look at evidence.
It's a good, very good idea. Yeah.
Yeah, hi. The increase in diabetes prevalence from 1980 to 2014 was much greater in men than in women. Is the reason for that behavioral or physiological?
There are multiple reasons for that. One is one of them could be that men has experienced a larger increase in BMI than in women, and men might be more likely to develop diabetes than women in at lower BMI levels, and also they might have some higher risk factors for diabetes.
If I could add to that, sorry. So there is actually, if you were surprised, there is actually a relatively good body of literature on what the people call sort of the change in the gender pattern of diabetes in the world. So in the US, where people have looked at this since the 1950s, there has been actually a switch. So women used to have higher diabetes, men have higher diabetes now in the US. And there are some studies, I mean, we mentioned this, that indicate that men actually get diabetes at a lower BMI than women do. So, or the risk goes up at lower BMI. So it's we were surprised, but it seems like people have actually looked at it for a few decades at this factor.
Thank you.
Those are all fascinating. So I'm a diabetologist, and this is all.
That's why I was going to look at you for answers.
Yeah, well, I'm sort of digesting. So I think the 1947 point is that there was a much lower prevalence of diabetes, but we have nothing to suggest that the ratio of type 1 to type 2 would have been any different. I'm having a quick look through the ages of those data. They were young and older adults. So who knows? And actually, I mean, throughout all of this, we've been talking about diabetes, but diabetes is simply hyperglycemia, and you can have hyperglycemia by any number of pathways, many of which we don't know. So, I mean, I think the diagnostic work that Shivani and we do clinically to differentiate type 1 and type 2 is really only things that we've started doing in the last 10 years. And we still frequently get it wrong, just between us. So, I mean, I think there's huge numbers of questions here about what happens in the type 1 diabetes population where T-cell regulation is different and where there are autoantibodies to different components, and whether the relative risks of TB and melioidosis in those populations may be different. I suspect we don't have the data to pull that out, but I'd love to know if the relative risks do sort of pull apart. And I suppose it would be really useful. I'm slightly spoiling Shivani's talk, which she's doing with the next one, but to talk about the diagnostics here and to try and pull out the different types of diabetes and the genetic forms of diabetes as well, which have a prevalence of 0.3, 0.4%, we think, in a white European Devonian population. But who knows what it is in India or China or Thailand or Laos, and it'll all be different. So I suppose there's a few specific questions. Do you think the survival difference from melioidosis was all accounted for in the first 3 days if you recruited them at day 4? So the survival was the same in people with diabetes without. Was that because the people with diabetes all died in days 1 to 3?
It doesn't seem to be from other data sets from my unit. There's also been a whole story about the role of glibenclamide in the treatment and whether there's some protection from the drugs, some immunomodulation. And there's been conflicting data on that. So it's not really known, but it is an area of active research.
That's very interesting. And your group that had no diabetes appeared to have an HbA1c on the plot that went up to 7%.
Well, I chose, that's my definitions.
Okay.
So
the WHO would say 6.5.
It's 6.5. I'm aware of that. I chose to be conservative because it was just on a one-off assay in a hospital which hadn't been validated. So if I change those cut-offs to 6.5, you get the same story slightly stronger. So I was just using a conservative definition.
I mean, there's loads of potential thoughts. Again, as you said there, Tanya, we don't know what's going on in North West London, let alone globally. I mean, if there's anyone who wants to talk about how we manage diabetes and infectious disease in North West London and pulling that together, I'm very happy to talk about that.
Well, yes, now and or next time, yes, please, yes, please, yes.
So if there's anyone who wants to,
do a bit now. Yeah.
Well, it needs a collaborator, doesn't it? So if there's anyone who wants to do that, I don't know, no one's putting their hands up. But we're very happy to talk to ID services about how we screen for diabetes, which is in itself very difficult, and using a glucometer, as you said, is a pragmatic solution which has sensitivity and specificity issues and cut-off choices. And did you think about using point-of-care HbA1c?
I'm testing that in my
in
my next study. I'm testing that
against a laboratory methodology.
Yes.
Which is, you said your laboratory methodology wasn't aligned, or wasn't.
Well, I've not independently validated it.
But in India, so in the routine health services, I mean, I think glycated hemoglobin is still more expensive than doing a fasting blood glucose. Yeah,
it is, but you don't have the recall issue.
Of course.
You don't then have to think about doing an A1C as a secondary test or a GTT as a secondary test.
Sure.
So if you accept the one value and say yes, okay, it has some limitations, but it's just one.
So this is sort of balance of what can be afforded. I think in Tamil Nadu, which is also southern India, there they've been screening with glycated hemoglobin, and interestingly, you get a higher yield at 6.5% compared with 7 with an FBG. So they pick up more so-called diabetics that way.
Well, that's because the impaired glucose tolerance that we tend to see more commonly than impaired fasting glucose in people from South Asia will predominate. So your HbA1c will be more sensitive to the post-meal glucose and will pick up more true cases, if you like.
Yeah, right.
You said something else very interesting. You said that there will be a false positive rate from screening at diagnosis. Do we know what that false positive rate is? Because we often talk about stress hyperglycemia, but in the walking wounded, I'm not sure it's going to be.
Yeah, no. Well, there's 4 papers published quite a long time ago in the 70s and 80s from Nigeria. I can't remember the other 3. Anyway, showing quite clearly that if you measure blood glucose in TB patients at the start, when they're registered, and then you follow it, the mean blood glucose it comes down. And then I was involved in a study in Iran, actually looking at glycated hemoglobin. And it's quite an interesting study, looking to see at the time of registration who was defined as having diabetes, and then looking to see what had happened with no treatment was provided. Actually, it was just TB treatment, and basically people's high glycated hemoglobin came down, and normalized, yeah? And then again, it was complicated, and some people who essentially had a glycated hemoglobin all right, say between 6 and 6.5, then went up. You with me? So it
they
was
were the progressors anyway.
maybe they were progressors, exactly. So it's an area where I think we need more research to understand what to do. It's at a program level, it is much easier to do your testing at the time you register the patient.
Yeah.
So obviously waiting, you're going to miss, there's going to be a problem with waiting, yeah?
And pragmatically, from a diabetes point of view, overdiagnosis and instituting treatment and public health measures and cardiovascular risk measures is a good thing, you might argue.
Absolutely. And in fact, the diabetic people we work with say maybe if you do have a high level at the time of registration and that normalizes, maybe you're at risk, a bit like gestational diabetes, of then going on and getting diabetes.
5 years, you
So
will have
exactly,
diabetes anyway.
exactly.
No, I think that's right.
Yeah, so maybe worth at least picking up that problem at that time.
Yeah.
I've got loads of questions. As Nick said, I'm doing a PhD at the moment looking at diabetes phenotypes and how they vary across ethnic groups in people with young onset diabetes. So I'm fascinated by the diabetes that associates with the infectious diseases that you've mentioned. But you also hinted at various phenotypes as well, talking about the lean type. And I wondered if you could just talk a little bit more about the phenotype that you're observing in melioidosis. Do they respond to oral treatment, oral hypoglycemics? Do they need insulin, or what?
I simply don't know enough about it, and I don't think the research is there, and it also depends on the drugs that are available. So a lot of the patients coming to this hospital are very rural, and they may just be put on insulin straight away because that's available, and you can't assume that they've been worked up through the drugs as they would be here. So we've actually been campaigning to get a diabetologist in situ there to research it, because it's clearly, and next door in Laos, we also have a research unit at Vientiane, Laos, and a lot of diabetes there, and it would be fascinating to have somebody with the expertise to unpack it all.
Because I think, like, if you're screening them with HbA1c, they're just thinking about it, a distinction between people who have very high HbA1cs,
Yeah.
who would therefore expect to either have had chronic hypoglycemia beyond the infectious disease, whether it's TB, and that there is a bit to unpick in that, because that's not always the case. Or whether they have sort of borderline slightly raised ones, which could conceivably be associated with the stress hypoglycemia of infection, and whether they progress or do different things.
Yeah.
That would be one simple categorisation to look at. But I'm also really interested in point of care devices and HbA1c. So I'm happy to talk about that as well, and how you would validate and which device to choose in an area that has a high prevalence of haemoglobin variants, for example. Those sorts of issues.
Great. I do have stored serum and plasma from my whole cohort, so that could also be a collaborative opportunity.
So, and your DNA as well, right?
Yes.
So, I mean, your whole protocol is to look at endogenous insulin production, autoantibodies associated with type 1 diabetes, and DNA, and to look at motor genes. So there's a real possibility to completely biochemically and genetically characterise your cohort in terms of type of diabetes.
So just, one of the reasons these forums are actually quite valuable. So actually on the phenotyping question, one of the things we have been interested in, so here we have got 4.4 million people since 1980, all of whom with a measurement. And we also have BMI on all of them, and we have actually placed on a good subset of them. The majority of them have got blood pressure, and quite a good few of them have got lipids. I mean, actually, we have been thinking about both phenotypes of individuals and countries, because it's not just a sort of a person that could have phenotype. It could be that you have countries, I mean, South Asia versus Northern Europe that have got differences. And so, on a very specific issue, actually, with Venkat Narayan that Danny mentioned, we are working on. So there are about 300,000 or 400,000 of these people who have got at least two types of glycemic measurement. So this is either fasting plus post-challenge, or fasting and hemoglobin A1c. In that case, we're actually comparing that, people who are diagnosed with one criterion versus the other. Do they differ in the phenotype? So that's a very specific one, and obviously the hypothesis is that South Asia versus European populations The fraction that we diagnosed based on glucose challenge versus fasting would be different, and perhaps the characteristics, but the whole 4.4 million people are actually there, the data, to actually look at the subset. We know that for majority of them, their previous diagnosis status, we know whether they are on medication or not. Actually, that would be a great thing to start looking at and what is the patterns of other cardiometabolic risk factors, blood pressure, potentially lipids. We actually haven't, so we actually got from these studies a subset of the data. Some of them may well have measured markers of infection in people also, so we don't know if we didn't even think about actually asking for these. So something to potentially consider. It could mean, the data are messy because they're coming from different studies and their formats and so on, but it is certainly a doable thing to actually look at those characteristics.
When you say markers of infection, do you have CRP?
We haven't asked for it. So these are data that people donate to us or give to us. So this is sort of a 700-person group, collaborating group that sort of we hold some of the data at the individual record level, some of it that people send us the summaries that we want. Certainly, if one goes sufficiently far, we could go back to people and say, look, have you measured these other things? I'll be shocked if at least some of those studies haven't measured it. Probably a smaller subset and probably the more recent ones. But
so the thing that I said about South Asia tending to have more impaired glucose tolerance and impaired fasting glucose is a sort of truism that we trot out all the time, but systematically showing that at country level for lots of different populations, I don't think has been done.
No.
And certainly not on such a large population, so there's huge value in doing that.
Yeah, so it is an area. So we have spent the past 3 years actually getting these data together. This is literally the first 2 papers that are coming out of the work. But one of the reasons was to actually have a resource for this, and I think the idea. I have always wondered, and we are now seeing that the rise in diabetes is a more complicated story than just the obesity story. There is some other things happening, and obviously, and actually, people's heights. So if that's probably the best marker of their early life nutrition. So we would be able to say something about what they were like as nutrition in early life, and what their BMI is. We don't know the rate of weight gain because we only get it at that cross section, and then what their other suite of risk factors are.
Yeah, height's fascinating because in children with type 1 diabetes, they tend to be taller at diagnosis. No idea why.
Danny, can I just ask a question about point of care tests? Could you expand a little bit about, because at a programmatic level, obviously a point of care test that's easier than an FBG or an FPG would be very useful. So can you tell us about costs, feasibility?
So I think there's been a real proliferation of devices that measure HbA1c at the point of care since the WHO revised their guidance in 2011 to allow HbA1c to be a diagnostic test for diabetes. But officially, none of those devices are valid for diagnosis. So you can imagine an assay that has to be used to diagnose something has to have acceptable precision and accuracy and perform really well. And conventionally speaking, the assays of a point-of-care device are not necessarily as robust as your in-laboratory assay that is quality controlled and quality assured. But putting that aside and being pragmatic about it, if we look at the current available devices, the newer generation devices, some of them are performing comparably to the laboratory assays, as long as they are acceptably quality controlled and users are trained and quality assured. So there's a bit of governance that goes with the device, but there's good evidence to suggest that if it has it there, then the result that you get is valid. Most of the point-of-care devices available use immunoassay technology. And without going into the details too much, that means that if someone has a hemoglobin variant and they're heterozygote for the variant, you can still get a result. Officially speaking, you're not supposed to use HbA1c if someone's got a hemoglobin variant, and so the converse of using an immunoassay is that you're flying blind. You don't actually know if the person's got a variant. So, but you've got to offset that against the benefits of having someone in front of you and screening them and potentially using that as a screening tool and then confirming it with a glucose measurement a bit later. Cost-wise, I know that the costs, there is obviously more cost associated with a point-of-care immunoassay, but again, probably not as expensive as people think, because you don't need venipuncture consumables, somebody trained in phlebotomy, a timed sample where someone has to have been fasted, or 2 hours later. So there is a cost issue, particularly in delivering the quality framework that goes with the device, but it's probably not as expensive as people think. And as more and more devices come out and the prices become more competitive, I think the cost will go down.
So what sort of figure is one talking about at the moment, roughly?
It's really
We
difficult.
asked last year, and the
Yeah.
cartridge, I think, was about £20.
£20, okay. $30, yeah.
I'm trialling a NiaCard system. Do you know that one?
Yeah, it's not got great.
Not great. I got it cheap. Yeah, that's probably the problem.
The other thing to say is that the evidence base, we're just writing some of this up. The evidence base that compares one device to another is not great. There's only been 2 or 3 really good, robust
Gold standard.
comparisons. And the other thing about point-of-care devices, they are very difficult to evaluate because it's not just how the assay performs in expert hands, but how does it perform in the middle of...
I'm familiar with this from malaria.
Yeah,
tests.
yeah,
It's
exactly.
the same story.
But all of that, I mean, you know, I'm trained in the laboratory and I'm a real purist about assays and it has to be precise and accurate, but you have to offset that with what's feasible. And, you know, you're going to get a result there and the patient doesn't have to be timed or fasted or come back.
And if it's high, they've probably got diabetes.
Yeah,
It doesn't matter
yeah.
if it says it's 7 or 7.5.
Yeah, so that's the thing, like you might not have confidence in it's gone from 8 to 7.6, but whether it's 5 versus 8.9, you will have confidence.
Yeah.
Yeah, I'm not sure whether this is off topic or quite relevant to today's discussion, but since we've got a few diabetologists and I thought I might as well ask, what's the utility and provenance of using apps, of using diabetics using apps to monitor, control, and keep on top of their diabetes? There's been a proliferation of diabetes apps over the past 3-4 years, both on iPhone and Android platforms, but how useful have they proved?
I have no idea is the answer to how useful they are. And if you do a search on the Apple App Store, which I did actually last year, there's about 1,030 apps that have diabetes as a keyword. Not one of them has an evidence base, not one of them is any way quality assured or offers any robust clinical governance. So it's an excellent question and a challenge that I think we're going to need to address as a diabetes and probably a healthcare community, because there's sleep apps, there's heart rate apps, and they're not governance, there isn't a framework for what you do with the data, and there isn't a framework for how you move forward with regulating them. So I don't know how useful they are. There is again an element of pragmatism. If you go to India and China, a lot of areas have completely skipped the landline generation and have moved straight to cell towers and mobile phones because that was the easy thing to do. We've done a text message study in Chennai where we've sent text messages to men with impaired glucose regulation, and we've shown reduction in the frequency of type 2 diabetes. So we've done a diabetes prevention study wholly using text messages. And I know that isn't an app, but you can imagine that delivering the same content in an app or in a smartphone way is equally effective and potentially more effective. But we're one of the few groups to have actually done that with a protocol and have an evidence base to do it, and we're repeating that study here. So yeah, it needs thought, and I think the FDA and regulatory bodies are starting to get wind of this and starting to get concerned that there are potentially adverse effects from this as well as benefits.
Thank you.
Actually, I just said there's a randomized trial in California of, so not for diabetes, but for sort of an app that uses ECG to I guess, transmit and get information. I mean, I suppose, you know,
is that with a Reveal device?
Pardon me?
Is that with a Reveal device or?
It's whatever it is that apparently use two probes to connect and measure it. So I heard it because a PhD student of mine who's looking at sort of the out-of-hospital fatality of MI. So I think somebody mentioned in that context. I don't know much about the trial, but I guess somebody has decided to do a randomized trial. I can ask and get the information, but there seems to be some people trying to do the app trials. since Danny has left, so I guess there is going to be tea, but just sort of before people go, the next forum will be on patient safety. It will be on 21st of April, and Gianluca Fontana from actually from IGHI will be the person who will be coordinating it. So slightly different time than the usual ones, and then in May we'll return to diabetes again, diabetes and infection. Thanks very much, and thanks to all the speakers.
It's really lovely.